our cancer genetics PDQ group, as well as the pediatric treatment PDQ group. So really thrilled to be able to have this. So a little bit of background about Dan. He's an assistant professor of pediatrics in the Division of Pediatric Hematology Oncology at Monroe Carell Jr. Children's Hospital at Vanderbilt. He received his bachelor's degree from the University of Pennsylvania and did med school at the University of Washington. He completed residency training in pediatrics at Seattle Children's before completing a clinical bioethics fellowship at Seattle Children's Katz Center for Pediatric Bioethics. He completed a fellowship in Peds Hem Onc at Dana-Farber at Boston Children's Cancer and Blood Disorders Center before joining the faculty at Vanderbilt and the Center for Biomedical Ethics and Society in the fall of 2018. Between his time in Seattle and Boston, he's also managed to complete a master's in bioethics at the University of Washington. And his broader academic interests lie in the intersection of bioethics and pediatric oncology, including complex decision-making and conflicts over treatment decisions for pediatric cancer patients. And also by way of background, Dan is in charge of managing kiddos with inherited cancer predisposition. So being a clinician in our hereditary cancer clinic at Vanderbilt, Dan is kind of our go-to person who manages these kids and advises on next steps and screens them. So Dan, we're really excited about your talk today. So I'll turn over the floor to you.
Thank you, Tua, for the kind introduction and invitation to speak. I'll make sure everyone is seeing my slides okay. And really, I'm going to talk about inherited cancer predisposition from the perspective of a pediatric oncologist. So I'm not a geneticist, as you did not list that in my background. I'm an oncologist, and really I've come to this sort of field in my experience over the last 3.5 years since joining the faculty here. And so that's really the lens with which I'll be approaching cancer predisposition. Briefly touch on some of the sort of historical approach that I, and I'm sure many others, were taught about cancer predisposition in children, how that has changed dramatically in the next generation sequencing era. Talk about what certainly my practice and many of my oncology colleagues' practices look like right now, caring for patients with inherited pediatric cancer predisposition, and then identify a few of the challenges and possible future directions that I certainly see as being valuable to our patients. So there's been long-standing recognition that some cancer is hereditary, and so retinoblastoma being a prime example of that. In the early 70s is when Knudsen's two-hit theory was published, and it wasn't until the mid-80s that the RB1 gene was identified, and the recognition that you really needed somatic inactivation of both alleles for tumorigenesis. Lee and Fromeini identified the cluster of families with childhood sarcomas and breast cancer and published the paper in 1969, but it wasn't until 1990 that P53 was identified as the mutated gene. But it's really 50 years of sort of knowledge and recognition of many of these sort of clusters and familial cancer predispositions. And for a long time, family history was really the focus, right? What I was taught in medical school was you take your good family history and that tells you whether there may be an inherited piece to this. And so when I meet a patient, that would have included, oh, is there a single cancer that runs in multiple family members? Is this child with retinoblastoma's parent also have retinoblastoma? Or eliciting that family history and realizing there's lots of different cancers in multiple generations. And that maybe that would then trigger a referral to a geneticist, or if this is the primary care provider getting this history, referring them to an oncologist. many problems with that approach. One of them is just time. There just isn't enough a time in a lengthy visit for many primary care providers or oncologists to take a really thorough family history, and oftentimes it's a low priority. Those early visits with a family, a new diagnosis of cancer, they may not know their family history, and it's not on the high priority list as we're talking about staging and treatment and things like that. The knowledge is quite specialized in terms of understanding the syndromes, the knowledge about how to send and which modalities of tests to send, how to interpret test results, and then the rapidly changing landscape and publications that are coming out make it really hard. What you learned 5 years ago may very well not apply anymore. And then access, we are lucky, we've got a number of geneticists and genetic counselors who have expertise in hereditary cancer, but we're a major academic institution, and so our colleagues at smaller centers just don't have that access, and so it can be hard. And even my colleagues have lengthy wait lists to get in to see them, and so these all put strains and oftentimes on the pediatric oncologist to sort of navigating this, especially in a patient with cancer. The other way that patients with cancer predisposition have been recognized historically is really through identification of a genetic syndrome. So the pediatrician or an oncologist sees some physical feature that makes them clinically suspect that the patient may have a genetic syndrome, and they may get referred then to a clinical geneticist who may identify a syndrome such as Beckwith-Wiedemann spectrum that confers a cancer risk, and therefore they now know that and can be referred for counseling and surveillance if indicated. As an oncologist, two of the first questions I get asked, so on an almost weekly basis, are, why did my child get this cancer? And are my other children at risk? And so the first one speaks both to genetics, but also to potential environmental causes. But really the second one is an understanding that parents and most parents have that there may be some genetic component or hereditary component to childhood cancer, or some fear about that. And my answer has shifted even in the not that long, many years I've been practicing in how I answer these questions. And partly, and the majority of that is due to the expansion of next generation sequencing. So in the last 6 or 7 years, there have been a number of studies and major centers looking at just applying NGS to both tumor sequencing, as well as obviously through somatic sequencing, we learned some information about the germline, but also centers that are starting to do more and more germline testing, really, and offering it to every one of their patients who have cancer, largely through research, though I know some places are really doing this as almost standard of care at this point. And so two of the major consequences is a recognition that these cancer predisposition syndromes are more common than we previously thought they were in patients with childhood cancer. And the second is really expanding the phenotype of known cancer predisposition syndromes. So in 2009 is when the association between pleuropulmonary blastoma and Dicer-1 was initially published. And yet now the phenotype of Dicer-1 syndrome continues to expand to include Sertoli-Leydig cell tumors, papillary thyroid cancer, cystic nephromas, Wilms tumor, rhabdomyosarcoma, pineoblastomas, and a number of other malignant and non-malignant tumors that are a part of the syndrome. So next generation sequencing, as we sequence all of these tumors, allows us to recognize these associations and then refine how we're counseling and potentially screening patients who have germline predisposition syndromes. So how many children with cancer do we think have these syndromes? Obviously, as I said, it's more common than we once thought. Incidence estimates vary. 10 to 15% is probably a reasonable range, though probably over time we'll learn that it's higher than that. But depending on the study, those are sort of where we are now. This is one example of one of the early studies that gave us that number. This was the Dana-Farber study that looked really at sequencing tumors to try and identify targetable alterations. And in doing so, identified information about the germline. And so they found this cluster here of blue patients that had possible cancer predisposition syndromes, and it was just around 10% of the patients enrolled in this study. And many other cohorts and groups have sort of found similar ranges. But this is one way that this number has sort of been estimated. And then more recently, there have been a lot of cohorts of individual cancer subtypes where institutions or consortiums have looked at the whole group of patients with a certain cancer type to estimate the incidence of cancer predisposition in that disease. And so this came from a European paper where by different types of tumors, they estimated the percentage of patients that had a germline predisposition. So almost about 80% of patients with sertoli lytic cell tumors have Dicer1. 70% of patients with pheochromocytomas have one of a number of cancer predisposition syndromes and down. And so this is just the group where the frequency is about 10% or higher. But so this is where a lot of these additional studies have followed from. So in sarcomas, people have looked at the frequency of these variants in osteosarcoma, a couple of papers in the last year in rhabdomyosarcoma, and then a little bit older, 2017 old in this field, paper on Ewing sarcoma and the frequency of DNA repair gene mutations in patients with Ewing sarcoma. And so it's led to sort of a list of sarcomas where if you have this sarcoma, really as an oncologist, I need to be thinking about the presence of a cancer predisposition syndrome. So anaplastic rhabdomyosarcoma and TP53, renal sarcomas with Dicer1, botroid type embryonal rhabdo and Dicer1, young patients with osteosarcoma and TP53, MPNSTs and neurofibromatosis type 1, and then PPB and Dicer1. In embryonal tumors, there's been sort of longer standing knowledge of syndromes associated with Wilms tumor, largely because the majority have multiple congenital anomalies, in particular of the genitourinary tract. And so we've known that association. This paper identified a more than 10% risk of having a germline APC mutation in patients with hepatoblastoma. And then an abstract at AACR last year identifying a much higher incidence of mutations in predisposition genes in patients with neuroblastoma than had previously been thought. It sort of had been suggested that there was the 1 to 2% who had hereditary neuroblastoma, but this identified a much higher rate of mutations in these genes. So for the embryonal tumors, retinoblastoma, obviously with RB1, rhabdoid tumors with SMARCB1, hepatoblastoma and APC, the bilateral or hereditary neuroblastomas with ALK and FOX2B, Wilms tumor, especially bilateral and multifocal tumors in patients with WT1 mutations or Beckwith-Wiedemann spectrum, desmoid type fibromatosis and APC mutations, and then adrenocortical carcinomas, well known with about half having TP53 mutations. This continues to expand. I'm not going to spend as much time on the leukemias and hematologic malignancies, but the list of genes associated with AML continues to grow and grow with more recent discovery and association with ETV6 and RUNX1, SAMD9 and SAMD9L, GATA2. ALL, it continues to expand. JMML, we've sort of known about the variety of RASopathies that predispose to JMML, and then a smaller group of disorders with non-Hodgkin's lymphoma. The CNS tumors, again, a sort of smattering across with SMARCB1 and ATRTs, TP53 associated with these CNS tumors, NF1 and optic gliomas, Dicer1 with pituitary and pineal blastomas, and then the variety of tumors that I alluded to earlier with pheochromocytomas and paragangliomas. And so as an oncologist, there's this much longer list now of diseases where the patient has that, and my brain and my colleagues, we automatically need to be thinking about this if we don't already know about it. Obviously, many of these, like neurofibromatosis, we were well aware of the clinical diagnosis ahead of time. A question that frequently comes up in our group practice is, well, when does timing matter? So when do how urgent is it that we make this connection between the cancer diagnosis and the predisposition syndrome? And there are many syndromes where that recognition may impact treatment decisions. That may be due to secondary malignancy risk. And so patients with TP53 and RB1, we want to avoid radiation due to the high risk of radiation-induced malignancies. And then if we have the luxury of avoiding alkylators for germline TP53 mutations, there are subsets of patients that have excessive treatment-related toxicities, and trisomy 21 we're usually aware of ahead of time. But then a number of syndromes with patients who really are more sensitive to our chemotherapeutic agents or radiation and do experience excessive toxicities. Potentially for prognostication, rhabdoid tumor has an abysmal prognosis to begin with, but in our young patients who have SMARCB1 mutations, that may impact our decision about our therapies and how aggressive to approach them, especially in some of the metastatic ones where the prognosis, the event-free survival is in single digits to begin with. And then occasionally, and at this point, it's sort of rare, where we may have targeted agents we might consider, for example, MEK inhibitors for NF1-associated malignancies. And so now, at least in my practice as an oncologist in this sphere, and a number of my colleagues at similar sized institutions, I see many patients for the purpose of either referrals for cancer predisposition or for doing the surveillance. And so I still get referrals just for a family history of cancer or a family history of a syndrome. Last week, I saw someone whose parent has FAP. And I think ideally that would go to a geneticist or a genetic counselor. And yet we can see patients very quickly in our clinics. We're sort of geared towards seeing referrals in a week or two. And sometimes that meets a family's level of anxiety or clinical need, whereas oftentimes a geneticist or a counselor has months of a wait list. And so these patients do still get referred to oncologists. The biggest area, though, is really post-cancer identification. So we have a patient in our practice with cancer, and one of any number of other features that should suggest a heightened sort of awareness that there may be a cancer predisposition syndrome, including a family history of that same type of cancer or other related cancers, the presence of bilateral and multifocal tumors or multiple cancers within the same patient, an earlier age at diagnosis than the sort of typical sporadic tumor. So that osteosarcoma in a 5-year-old should have a heightened sort of awareness rather than a 15-year-old. Any physical exam findings suggestive of a syndrome. And then a growing list, as I've already suggested, of tumor types that really should raise our awareness. And then again, the much higher frequency of tumor sequencing that's going on either upfront or at recurrence, which leads to secondary findings and suggestions of a possible predisposition. And then this topic of excessive toxicities, and I put a question mark there largely because I don't think many of us know how to define excessive toxicities. I think there are some patients who just get every possible toxicity, and we sort of say, well, that seems out of proportion. But what level threshold that is, and even what genes we're going to go hunting for isn't always clear, at least based on the literature and discussions our team has had. And so any of these things should sort of indicate a referral to a geneticist and an offering of germline testing. In the last couple of years, there have been a number of groups who've published sort of tools to try and help the oncologist sort of understand who is at risk. And so this is one of the original ones out of Europe. And Youngmans and her colleague, the colleague said, if your patient fulfills one or more criteria, they may benefit from referral. So that's, again, family history, personal history with any specific tumor type, 2 malignancies, congenital anomalies, and excessive toxicities. And this was the initial list that paper suggested should trigger sort of heightened awareness, and this is 6 years ago. Another tool is developed at McGill, and so the group there developed an online tool that's now an app to help identify this. And so this is the MEPOG, and you can go to that app or website, and you can download an app on your phone. And it really, there are tumor-specific algorithms. So I take my patient with Wilms tumor, and it's going to ask me a number of yes or no questions that's going to lead me to a recommendation about whether genetic evaluation should occur for my patient. And so these are two of a number of sort of tools and efforts to try and figure out how do we help oncologists, and how do we make sure we're not missing patients who historically probably have not been captured as having cancer predisposition syndromes. At Vanderbilt, we sort of took these tools and all the papers and synthesized this, and so this list is far longer than the Youngman's initial list of tumors, malignant and benign, that trigger an automatic referral to our cancer geneticists or counseling at VUMC, and we're sort of starting to implement this in the last year or so to try and make sure we're not missing patients. The last aspect of sort of what this practice looks like for me as an oncologist is around cancer surveillance. And so once the geneticist or someone confirms the presence of a cancer predisposition syndrome, we then have to decide, does this patient warrant surveillance? And so considerations at this time largely are based on consensus statements and guidelines, of which there are a number published about 5 years ago. Data, but at this point there are very limited data that sort of guide us on whether, when, and how we should do that, and then on family preferences. Where surveillance occurs may vary based on the institution. As I said, many times this is coming to an oncologist. For some diseases and at some institutions, it's geneticists doing the surveillance and ordering the scans or tests. And then for some diseases, the primary care providers may be doing it if they're managing patients with Down syndrome or Beckwith-Wiedemann and helping coordinate these. So some of the consensus statements in 2016, there was an AACR childhood cancer predisposition workshop where they recommended and came up with these surveillance protocols that they said were designed for asymptomatic individuals genetically predisposed to developing cancer. Though they recognized many kids are identified actually after the development of their first cancer, but that was the sort of lens through which these guidelines were developed. So it doesn't necessarily perfectly apply to the oncology patients that I often take care of. And one of their major questions was, when should we or whether we should do surveillance? And so they came to consensus and that surveillance was recommended when there was a 5% or greater risk of developing cancer during the first 20 years of life, and when effective screening modalities exist. And that it was not recommended if it was under 1% risk of an individual malignancy during the first 20 years. And in between, they supported surveillance if the modality was cost-effective, non-invasive, or if the outcome was so poor for what they called clinically detected tumors that any possibility for early detection might enhance survival. In Europe, the European Society for Pediatric Oncology, or SIOP-E, hosted a working group and came to similar recommendations for thresholds for screening, a risk of cancer of greater than equal to 5% by 20 years of age. Though they sort of refined that in the 1 to 5%, they said you should discuss it with the family and consider things like the anticipated survival benefit, the cost, availability, and feasibility, risks of surveillance, and the psychosocial burden of surveillance for the child and family. So very similar, but I think there's some subtle nuances there in that 1 to 5% in the European and more American-centric approaches. Important to note, these are largely solid tumor focused. There are not really consistent recommendations for leukemia surveillance, except in patients where the syndrome they have is associated with preceding myelodysplastic syndrome or bone marrow failure. There have been some cohorts of patients who have been found to have improved outcomes with allogeneic stem cell transplant when used prior to the development of AML. And so based on that, some in centers and for some disorders, folks are doing CBCs with or without annual bone marrow evaluations to sort of look for evolving MDS or bone marrow failure so that they can intervene with stem cell transplant ahead of the development of AML. What about actual evidence that these guidelines or that screening makes a difference? Well, this is at this point fairly scant, and they acknowledge this, and Broder and colleagues said for most cases, evidence will have to wait and await the implementation of the recommendations proposed in the position article. So these are, they knew we're putting these out there as guidelines, and then over time we can sort of evaluate how well are people able to adhere to these, and do they make a difference in terms of the stages of cancers detected and the prognosis for those diseases, things like that. There are a couple of areas where we do have some publications, and Lee Farmani, the group published on their experience with their surveillance protocol. So this was published in 2016, and they had done physical exams, biochemical, and imaging. This was at 33 centers across the US and Canada over about 11 years. And patients were allowed to choose whether they wanted surveillance or not, and crossover was allowed. They looked at the outcomes of detection of asymptomatic tumors as the primary outcome, with a secondary outcome of looking at 5-year overall survival of the tumors based on whether they were detected by symptoms or based on surveillance imaging. In the patients who were followed with surveillance, they identified 40 tumors in 19 of the 59 patients in that group, so 1 in 3, with a cancer survival of 84% and an overall survival of 88%. Those who were not surveilled and just had tumors identified by symptoms, there were 61 tumors identified in their 43 patients, in 43 patients of the 49, and the cancer survival was under 50%, and an overall survival of around 60%. So it suggested that surveillance makes a difference for the Lee Farmani population, and there are fairly well outlined guidelines for what that surveillance could look like or should look like. The other area where there are data is in Beckwith-Wiedemann syndrome and Wilms tumor screening. A couple of papers around 2000. One looked at patients who developed Wilms tumor with Beckwith-Wiedemann based on whether they had had some screening or no screening, and found a full stage, lower stage of tumors in patients who were having tumor screening done. They also, a group looked at the National Wilms Tumor Study data, so thousands of patients looking back, and said, of the patients with Beckwith-Wiedemann, they were seeing a trend towards smaller tumors being identified over time, which they were hypothesizing was related to the sort of increased uptick of people doing surveillance for patients with Beckwith-Wiedemann, because there had been a number of published sort of surveillance guidelines. More recently, a group looked at the interval of screening. And so they looked at tumors in patients with Beckwith-Wiedemann based on whether they were having ultrasounds done at under 4 months intervals, so 3 or 4 a year, versus over 4-month intervals or no surveillance at all. And they found that 12 patients had tumors identified with surveillance imaging done every 4 months or less frequently, and none of them were stage 3 and 4 tumors. And the patients who were having ultrasounds done at 5, 6 month intervals or greater, almost around 40% of them had stages 3 and 4 tumors. So suggesting that that interval does make a difference in sort of the earlier detection of smaller and lower stage tumors. Another group tried to look at cost effectiveness of screening, and they demonstrated in their model that there was a cost benefit of doing every 4-month ultrasounds up until the age of 7 in patients with Beckwith-Wiedemann. But this is sort of at least right now, the limit of what we have in terms of sort of objective empiric data on whether and how to screen for many of these tumors. Really, largely, these are consensus guidelines. So at the end, I was going to just talk a few things briefly about some of the challenges and limitations in our current both literature and the challenges as an oncologist to practicing in this space. One is, as these publications come out and we realize how many of our patients have this, we have a lot of patients for decades who are in survivorship. And so they may be followed in survivorship clinics through pediatric oncology centers, but they may not be. And so the knowledge that your patient may actually have a cancer predisposition syndrome may not be reaching many of our survivors of childhood cancer from the last few decades. And so figuring out how do we reach those patients now to help them and counsel them and offer them testing. And so that's going to take some thought. The other is the issue of second malignancies. As I said, the guidelines were really developed based on the data on the incidence of the first tumor developing in a child with that predisposition syndrome. And yet we know that some diseases, there really are genotype phenotype differences. So Lee Fraumeni, for example, if you have a p53 mutation, which one you have may confer different malignancy risks. There are going to be treatment-related factors. Once they've had cancer once, did they get radiation? Did they get alkylators? Are there other aspects of their treatment that might modify their risk of developing a second malignancy? And then what I see is many of my patients, once they have cancer once, their families have a much higher tolerance for screening. So even though it may be a 1 or 2% risk of that other cancer, I think the families are far more willing to tolerate doing blood monitoring or imaging surveillance for the development of that tumor because their child has already had one and they're getting followed for that tumor. And so our thinking about the burdens of surveillance for a patient it'll be different in these patients with second malignancies. A patient of mine, to give a sort of example of this, was a 2-year-old with hepatoblastoma. He had neoadjuvant chemotherapy and unfortunately had an unresectable tumor, and so went on to undergo liver transplantation. He had some genetic testing for Beckwith-Wiedemann spectrum, and then a panel through our geneticists that included APC, GPC3, TP53, and a number of others. And when that was negative, they still had some suspicion for a clinical syndrome based on the sort of clinical phenotype here. And so they did whole exome sequencing and identified a pathogenic variant in NSD1 consistent with Sotos syndrome. So Sotos syndrome is at present, based on the guidelines that have been written, there's a recommendation against cancer surveillance for patients with this due to they have a number of tumors that are at risk for hepatoblastoma, neuroblastoma, sacrococcygeal teratomas, maybe Wilms tumor, but the incidence isn't very high of any one of those. And so the current guidelines recommend against that. But my patient already had one cancer, has received chemotherapy, is going to be immunosuppressed for the rest of his life for all of his monitoring, his liver transplantation. And so his family, the added burden of doing ultrasounds and lab draws to look for neuroblastoma, catecholamines, or to look for a Wilms tumor, there isn't much added burden to this child. And so their family were very interested in tumor surveillance, and it seems very reasonable to do so in this case. As I alluded to, the AAC workshop very explicitly said we didn't address implications for second cancer and subsequent surveillance. Recommendations will need substantial personalization, depend on the child's risk of a second tumor, taking into account their risk of recurrence, the therapy, the biologic nature of the syndrome, et cetera. This is going to be hard for a pediatric oncologist who doesn't spend a lot of time thinking about understanding it. I don't understand all of the biologic nature of all the surveillance or the syndromes, and so I lean on my geneticists and having a discussion about these things. But this is a lot for your most pediatric hem-onc doctors to sort of be up on these data. Another challenge is that recommendations come in all forms. And so there's those guidelines that are sort of consensus from experts. And then there are publications where people just say, this is what I recommend. And first, the guidelines may have variability. So there's a number of different Li-Fraumeni protocols that you can follow. And so which one you follow is going to be different, and patients are savvy and they'll learn about that and ask, why aren't you doing CBCs when this other person is, and things like that. And the other is that there are a lot of case reports that are continuing to get published. And so here's just one that I think has a somewhat controversial recommendation. So there's an association between germline mutations in SMARCA4 and small cell carcinoma of the ovary hypocalcemic type, or hypercalcemic type, or SCOOT. And these authors published a case where they did bilateral salpingo-oophorectomies in a minor, in a 13-year-old. She had lost her mom and aunt to this cancer. It's a very aggressive cancer with a really poor prognosis. And the authors said prophylactic removal of the ovaries is the only viable prevention option for germline carriers of this. And they were advocating that that was an approach that was should be considered. But this is an incredibly rare disease to begin with. The predisposition is rare, and I don't think there is much data on the penetrance of it. And so how confident can we be in that recommendation? It certainly raised a lot of questions for me when I read this paper about whether that was the right thing to do for anyone, let alone a minor, where there's certainly different ethical considerations for undergoing that type of surgery. And the last challenge I'll just raise is what to do when we find patients with multiple predisposition syndromes. And this is happening more and more as we do more next generation sequencing, especially as in large centers where germline sequencing is sort of becoming more common. I have a patient who had a sacrococcygeal teratoma. It was resected, and he was evaluated by genetics due to multiple congenital anomalies. A microarray was unrevealing, but whole exome sequencing found, again, a mutation in NSD1, so it's a different patient, but also a pathogenic variant in SDHA, which was consistent with hereditary pheochromocytoma and paraganglioma syndrome. So how and when might we screen this patient? As I said, the current recommendations are against screening for Soto syndrome, but now we've added in that this child is, in addition to being at risk for these tumors, at risk for pheochromocytomas, GISTs, renal cell carcinomas. And so do we have any data about how these two mutations might impact, or whether there's any synergy or impact on their cancer risk? I don't think we have any data right now. And so maybe someone could try and do some really elegant models in zebrafish or some other animal model. But practically, we just have to decide for this patient, what should we do? And so that was a sort of situation. I met with the family and talked through the options, and we came up with something that seemed acceptable to them because they were very interested in doing some additional screening. So the last thing is on some future directions. I mean, one is really developing evidence. As I said, we have proposed guidelines, but we don't know which of those guidelines are actually going to lead to improved outcomes at this time. And so hopefully we can study and learn how well are oncologists adhering or geneticists adhering to them, and what is the impact on cancer detection and outcomes, and then refine those guidelines based on data. Training is a huge area, especially from my view in your pediatric oncologists. I don't think we're trained very well on how to obtain or document a very thorough or appropriate 3-generation family history. And so I benefit immensely from Tua and her colleagues and looking at the pedigrees they draw and seeing the histories they take. But I think this is an area where we just don't spend enough time and we don't get enough training. The other is in actually understanding the nuances of germline testing. There's a lot of evolving technology around which tests and understanding which ones are the right ones to send, when is a single gene, when would you use a panel, and other modalities of when you're not even dealing with just, for Beckwith-Wiedemann, for example, you're not just doing sequencing. Around counseling families and obtaining truly informed consent. And, we need more genetic counselors, but that there are not enough of them, and they certainly aren't embedded in most pediatric oncology clinics. And then also training in interpretation. I see variants of unknown significance misinterpreted far too often by colleagues, and that's just a limitation in sort of understanding of where we are right now in our ability to interpret those and all the different variant classifications. And then I think an interesting area is in implementation science, figuring out how do we integrate tools like that MEPOG surveillance tool or others into our EHR. If our EHR says we have to put in that the patient has this specific cancer type and it gets an ICD-10 code associated with it, well, can we build something in that so that we're actually recognizing and automatically flagging patients who have that, or their family history was imported appropriately, and that they really should be getting referred for genetic counseling and screening. And I think this is an area where we've certainly talked in our group about figuring out how can we have a dashboard to look back and say, did we do, when we started to implement these standards, how did we do in terms of not missing these patients? And so I do think there's some areas where we can try to do a better job from a system standpoint as well. So that's what I got. In summary, many childhood cancer patients have these predisposition syndromes. Access to geneticists and genetic counselors are inconsistent. And as a result, really pediatric oncologists need knowledge about these syndromes and navigating all the issues I've raised, and in particular in an evolving and rapidly evolving landscape and knowledge. That's what I've got, and I'm happy to answer questions or just have this be food for thought. So thanks everybody for attending and listening, and I'm happy to, as I said, field questions or hear any comments people have.